Well, let's see how the sound system's working today. Hello out there in television land. Can you hear? Again, since this is just a hearing, we'll dispense with the roll call. The purpose of the hearing today is to discuss the scope of practice for optometry. As you know, the statutes of the state of Mississippi actually set forth the limits on the practice of optometry. Over the years, those procedures have been expanded. There is a proposition to simply allow the State Board of Optometry to establish rules for the practice of optometry. In any event, the question that presents itself is, what are the procedures which optometrists should be allowed to perform that they're not currently allowed to perform under state law? So what I'm hoping to do today is have a presentation and a discussion about those various procedures, and so that we can all learn more about them. At the end of the day, we'll vote on legislation sometime next year, but this is the first step in just trying to get members of the committee familiar with the various propositions that are out there. So our first speaker, I believe, is Dr. Stephen Reed. Dr. Reed, are you ready to go? Well, just come on up. And I would suggest to members of the committee that just as a matter of procedure, I think it would do well to let the optometrist present their presentation. And then I understand there's a presentation from a group of ophthalmologists in the State Medical Association. And I would suggest that at least during these presentations, we have questions only for purposes of clarifying something or trying to understand a statement or something, but just rather narrow questions, and so we can get through both presentations. And then after that, there'd be an opportunity to ask questions and get, I guess, a back and forth. But I believe we'd do better if we sort of went through everything and then sort of asked questions at the end, so everybody who wants to respond to every question will have a chance to do so. So having said that, Dr. Reed.
Great, thank you so much. First of all, can you guys hear me okay? I heard there was a little issue with the sound. Okay, perfect.
Say what?
Got it, okay, I'll speak up. Before I begin the presentation, and it's going to take just a moment to actually get the slides rolling, I was thinking when I walked in the room that the last time I was in here earlier in the year, we had no idea what 2020 was going to throw at us. I don't think anybody here could have predicted that. And I just wanted to take a moment to tell all of you guys thank you, because I know this has been a very difficult year to lead. It's hard to lead in a crisis.
The prosecution rests.
Okay. Okay, we good now? All right. So as I was saying, you know, it's hard. It's difficult to lead in a crisis when you don't know what's going to happen next, and you guys have done a great job. I know you've made a lot of very hard decisions, and I just wanted you to hear someone say thank you, because I know lots of times when you hear from the public, it's not always a thank you. So we appreciate your support and your leadership in the state of Mississippi. Let's go ahead. Let me see if my slide deck is working here. Okay, we're going to go ahead and just cut to the chase about why we're here today. Our Practice Act in Mississippi really needs to be caught up to the 21st century. It has not been updated since 2005. And for those of you that know what a bag phone is, God bless you, we essentially have a bag phone in Mississippi where all the states around us are playing with a smartphone. Also, it's not just about the Practice Act, it's ultimately about improving the overall health care in the state of Mississippi, as we'll discuss a little bit later on. And today also is really not about optometry versus ophthalmology. It's about the people. And I want to show you that on this slide are actually real patients. These are not stock photos. These are real patients that we have seen. I remember years ago when I was in kindergarten, I was given a coloring sheet of a stoplight. And I was asked to color it. And of course, I did the red, I did the yellow, but I left the green white. And my teacher's like, why don't you finish it? And I said, well, it is finished. And she said, no, you need to color the bottom green. And I'm thinking, why in the world would I do that? It's white. So I knew something wasn't quite right, but I didn't know what at that time. When I got to be in third grade, I couldn't see the board. And so I did have to get my first pair of glasses. And I want to just tell you, I felt kind of like a freak. Here I am, this third grader that's awkward anyway with a big pair of glasses, and I can't tell what color things are. And I really remembering praying to God. I said, God, please heal me from this, so that I don't have to wear glasses. I don't want to be embarrassed. And I didn't know it at the time, but that was not his plan. He said, I'm going to use your problems, and I'm going to turn you into an eye doctor to be an optometrist, and I'm going to use that to help people. So I want to remind you guys, that's why I'm here today. It's really about the people. Let's go ahead and tackle this big word, surgery. Now, it may surprise you, but optometrists in Mississippi already perform eye surgery. Surgery is defined by the code. Now, I know when you think of surgery, and most people, you think of the hospital setting, the bright lights, the gown, the mask. Well, of course, we're all used to masks these days. But you're thinking of the major surgeries. We are not talking about major surgeries today. Just make sure you know we're off the table with that. The reason I said optometry already do surgeries is the insurance codes which define those actually call something as simple as pulling an eyelash surgery. Kind of ridiculous, but that's what the insurance codes call that. Out of all the ophthalmic surgical codes, about 20% are considered to be minor surgical procedures, which falls a little more than pulling an eyelash, but along the lines of what we're currently trained to do. In Mississippi, we are allowed to do about 9% of those procedures. Updating our Practice Act would simply give us the ability to practice what we're taught in school right now, what surrounding states are doing, which I'll show you a little bit later as well, and would enable us to serve the state of Mississippi better with our patients. Now, I also want to point out to you, we are not talking about any procedure today in which you're put to sleep. We're not talking about any procedure today where we penetrate the ball of the eye, we cut into the eye. And we're not talking about any procedure where we inject into the ball of the eye. Over 80% of those are the complex procedures that are off the table today. So I want to make it real clear. We want to be as transparent as possible. Also in our bill, we are very clear to spell out what we are not asking to do. We are not asking to do cataract surgery. We're not asking to do retinal surgery. Okay? We're not trained in those areas, and we know that. We're just simply asking to be allowed to do what we're trained in the first place. Let's talk about safety. Now, safety is not an issue either because there have been states around us where the optometrists have been performing these procedures for many years. You know real quick how safely that's been happening by the malpractice rates. One state has been performing these procedures for over 30 years, and there has been no rise in the malpractice rates. And I assure you, if there's something that happened, somebody in insurance would have found it. Also, there's been some concern about the safety of the state board regulating the practice of optometry. We're the only doctoral level profession in the state where the state board doesn't regulate them. We are not looking to do brain surgery, and that's not going to be an unintended consequence of this, okay? The oversight by the state board, it's important to know, they answer to the public, not to optometry. And you guys already know this, but there is additional oversight from an Occupational Licensing Review Commission, which you guys established. So there's plenty of oversight. Safety is not an issue either. Now, I don't intend to turn you into an optometrist, but it is kind of important that you have a general idea of what we do every day. We are primary eye health care providers. When you hear that word primary, what I want you to think is we do most procedures most of the time. We take care of most of your problems. If you have a tooth problem, you're likely to go to your dentist. And your dentist, more times than not, is going to fix that problem most of the time. That's what primary care typically does. Our role is diagnosis, treatment, management of diseases and disorders of the eye and visual system. Also, we play a very strong role in working with other healthcare professionals in the diagnosis and monitoring for many systemic diseases. Matter of fact, there are over 270 systemic diseases, bodily diseases, that can have an impact on the eye. So when we're trained, we're not just trained on this one little eyeball, we're trained on your entire system to be able to diagnose and manage. And some things up here highlighted, diabetes is one that always comes to the top. If I see a patient that's not a diabetic, I'm wondering when they're going to be. Sickle cell, maybe not one you think of, and certainly brain tumors. Every optometrist in this room at one point in time has diagnosed a brain tumor that the patient didn't know that they had. Let's talk about education and training for just a moment. Now, it's a very text-heavy slide. I do not intend to read all this. I'm going to point out some just a few key points here. The first 2 years of medical school and dental school and optometry school are very, very similar. All three programs are a 4-year postgraduate program. And the 2 years that start out are pretty much your core classes, things you think about such as anatomy, physiology, and so forth. The difference between optometry and ophthalmology is that in the 3rd year of optometry school, we start focusing more on the actual eye issues and how they relate to the body. We start getting into that at that point. Med students, although I didn't go to medical school, this is what I hear, they go through a series of rotations at that point. And then it's not until an ophthalmologist actually enters their residency later that they are allowed or start learning more about the eye itself. So we started in year 3. When we graduate, we do have the option to do a residency if you want to further, say, subspecialize in a particular area. I want to point out as well that after graduation, we are required to have continuing education just like other professions. And in Mississippi, we are required to have at least 20. I'm board certified, and so I get about 33 per year, but it's at least 20. And we put the GPA of some students from Southern College of Optometry and UAB on the bottom because, these are bright students, just like dentistry and med school students. Optometry is not a default profession. I mean, people choose that, and they're it's very competitive. So we're talking about very bright people that are entering the profession there. Wanted to show you a few classes. As I mentioned, on the first couple of years, you've got the core classes, anatomy, histology. There's cardiovascular as we talk about those systems as it relates to the eye. And then there's year 3 where we get a lot more vision and eye specific. We do have classes in injections and minor surgical procedures as well as ophthalmic lasers. So we are trained in those areas. And when we graduate and take the national boards, there is both a clinical and a didactic portion of that on the lasers and advanced procedures. Let's talk about access to care for a moment. So in Mississippi, optometry is in 72 of the 82 counties. You can see by the dots, we covered the vast majority of the state. By contrast, ophthalmology is in 35 of the 82 counties and primarily focused in the more urban areas. So the reason we put this up is that in Mississippi, optometry does provide the vast amount of eye care to the state, mainly and particularly in the rural areas. I also want to highlight that even though today we may have some opposition, the truth is in Mississippi, optometry and ophthalmology get along very well for the most part. We have a lot of close relationships. I have some great friends that are ophthalmologists, and when I do my job and they do their job and we work together, it's the patient that benefits. So don't think this is an issue all over the state. It's really not. We work hard to work together for the benefit of the patient. So let's talk about what we call brain drain. In the last 5 years, there have been 27 doctors of optometry who have chosen to either move away or not come back to Mississippi to practice. Like the rest of the country, the citizens of Mississippi are getting a little older and we're becoming more numerous. And we currently have open spots for optometrists. I could probably hire 2 right now. So it gets more difficult when these optometrists don't want to come back to the state because they're not allowed to practice as they're taught. And I'll show you in a few minutes, they can easily go next door to the state of Louisiana. They can go to Arkansas. They can go to several. Well, I'll show you that later. The point is, they can go any place and practice at a higher level around Mississippi than they are here. So we really need to provide every incentive for our doctors to come back to the state. You've heard it said before that doctors are an economic engine. Let's talk about that as it relates to optometry. An economic impact study from Southern College of Optometry said that when a graduate comes back to Mississippi or goes to a state, on average it takes about 3.5 jobs to support them, either if they go into a practice or if they start a practice. So we're creating about 3.5 jobs per graduate. Of course, as you guys know, when they graduate and go back to a small town or their town of choice, they're likely going to buy a house and they're going to become a part of the community, buy locally, have a family. And if you add all that up, it's about $1.5 million. Let's do the math and go back. I mentioned to you before 27 doctors have chosen not to come back in the last 5 years. That averaged out means we've lost about $8 million per year from our economic engine, just not providing an environment that some optometrists want to come back and practice in. Here's that map I wanted to show you. Every state around Mississippi, every state, the optometrist can practice at a higher level than what we can. We are an island sitting there. That's why it's so attractive that we actually have some doctors that want to go back to Louisiana. Now, we actually, on the opposite side of what I said, have 2 optometrists here today, Dr. Lori Blackmer from Picayune. Lori, if you'll raise your hand. And Dr. Delia McKinney Evans, if you'll raise your hand. These guys are both dual licensed. Dr. Blackmer is licensed in the state of Louisiana. She practices in Picayune. She can very easily, and does, go across the state line and perform procedures that she cannot in her own practice in Mississippi. And Dr. McKinney Evans has a dual license with Oklahoma. For years, she practiced there and was able to perform these procedures, but yet comes to Mississippi, which we're thankful she wants to be here, and she can't do those. So there's 2 examples in the room of doctors that are trained that can and have done it elsewhere that cannot in the state of Mississippi. Let's talk just a moment about improved health care and cost. What we mean by timely care, if I have a patient in my exam chair that needs one of these procedures that I can do, it's so simple. I either leave them in the chair or I wheel them next door to the next room and take care of that. That is timely. If I can't do the procedure, then what I have to do is we have to call to make an appointment with the ophthalmologist, and that patient has to wait to get that care. It's also not very convenient if the patient needs an additional appointment to go and get this care from another doctor. And it's not only inconvenient for the patient, but a lot of times for the caregiver. Many elderly patients need a ride. And sometimes it means people taking off work for an additional appointment that would not have been necessary if I could have performed the procedure in office. Improved care, there are some patients that choose to not get the care. Okay, it's difficult to drive the 20, 30, 40 miles to see the ophthalmologist. And some patients just can't do that, and so they would rather and choose to not get the care at that time. And less costly care, many of our patients today with commercial insurance and with your Medicare Advantage plans, they have a copay. And so a patient that comes to see me has to pay the $25, $35, $40 copay, and then if I have to send them to the ophthalmologist, they're paying that again. Now, that might not sound like a lot of money to you, but I hear all the time when you're on a fixed income, $25, $30 does matter. It's also less costly for the healthcare system because guess what insurance is doing? They're paying twice because when we send them to the ophthalmologist, they're not just doing the procedure. They're going to repeat the test. There's going to be an office visit. It's more costly care overall. I want to come back to this slide again and just remind you again as to why we are here today. We want to update our Practice Act, which has not been updated since 2005. We want to get us into the 21st century. We want to be able to practice in Mississippi to the highest level at which we are trained. Again, there's the analogy of the bag phone. If you had the blessing of having one, you know what I mean. And overall, as I hope you've seen, by doing this, we actually improve the health care in Mississippi. I also want to hit this real fast for you. We're already doing surgery. We're just simply wanting to add to what we currently do. Our bill is being very transparent. There are no loopholes in this thing. We actually spell out for you what we do not want to do, because we want you guys to know, hey, if we tell you this is what we're looking to do, this is what we're looking to do. We're not wanting to do these complex surgical procedures. I've shown you that access to care, patient care, and savings are improved overall by allowing optometrists to practice at the level they are trained. Safety is not an issue. There's plenty of oversight with the state board, the Occupational Licensure Review Board, or Review Commission, and also our malpractice claims. I've heard it said before, well, we just don't have enough data. Well, you know, 30 years is enough time to get data, so I think we do that shows that optometrists are more than capable of doing these procedures and doing those safely. I wanted to remind you one last time that I'm standing here today, it's really about the people overall. And I love what I do every day, and I'll tell you that the one thing I love the most about this slide are the smiles. Because I'm going to tell you, when you have the ability to fix a person's eye problem and make them smile, that is the most rewarding thing ever. So I want you guys to please help us update our act and help us to make more people smile in Mississippi. I would like to stop my portion of the presentation and introduce to you Dr. Chris Roten. Dr. Roten and I are colleagues. We both graduated from Southern College of Optometry. He practices in Louisiana, but he does have some Mississippi connections, which I'll let him tell you about that. He's going to talk to you today about what it's like to be a doctor practicing in another state that actually does these procedures himself. So, Dr. Roten, I'll turn the floor to you.
Thank you, Dr. Reed. Mr. Chairman, members of the committee, it is an honor and a privilege to be with you today, and I know you've got a lot on your plate, so I will be brief. My family is from Bude, and I still have relatives there, and I've always considered Mississippi a second home, but as Dr. Reed mentioned, I currently practice as a board-certified doctor of optometry in Louisiana, and I currently serve as our state regulatory board president for optometry. It's certainly not my place to tell you how to vote on any issue, but I am here in support of this legislation and can definitively attest to the safety and benefits that it offers to patients. A very similar scope bill to being what's considered here was overwhelmingly and bipartisanly passed by a margin of 2-1 and then signed into law by Louisiana Governor Bobby Jindal over 6 years ago. As a direct result, Louisiana citizens and some citizens of the Magnolia State as well along state lines have benefited from increased access to quality eye care. In fact, citizens in several areas now have direct and timely access to these eye care procedures for the very first time ever, thanks to trusted doctors of optometry who practice full-time in their rural communities. I've personally done hundreds of these procedures, and my colleagues in Louisiana have safely and effectively performed nearly 14,000 laser procedures alone since passage of this bill. To date, there have been 0 complaints to our state regulatory board by patients, by our Attorney General, or by the state medical board regarding any of these procedures. And we're not aware of any malpractice claims regarding any of these procedures as well. As further testament to how safely these procedures have been done, as Dr. Reed mentioned, malpractice rates in Louisiana have not increased a dime as a result of passage of this bill. It is rare to have the opportunity to improve health care outcomes and at the same time reduce health care costs. Yet this legislation will do both by removing the duplication of exams currently necessary as part of the referral process, as Dr. Reed mentioned. Further, it eliminates the extra travel costs and time requirements which encumber patients and disproportionately affect both senior citizens, rural citizens, and the underprivileged, for whom traveling hundreds of miles round trip to receive this care is a significant burden and a very real barrier to care. These barriers force some patients to delay or even forego these necessary procedures, resulting in worsening disease and higher costs to the healthcare system in the long run. The issue of access to care is real. Just last week, the American Medical Association put out a policy admitting that access to care can lead to poorer healthcare outcomes, specifically in minority communities. The U.S. Department of Health and Human Services projects this year that approximately 1 in every 4 patients nationwide needing eye care services like these may be unable to access them due to the limited supply of current providers. And that does not factor in doctors who do provide the procedures but no longer accept certain insurance coverages for them, further restricting access to care. At the end of the day, the procedures being considered here have been safely and effectively performed by doctors of optometry for over 3 decades, which is indisputable evidence of the training and decision-making qualities they possess. As already stated by Dr. Reed, not only do doctors in optometry already perform surgical procedures in Mississippi, many of those are more challenging than the ones this legislation would allow. In summary, I've seen firsthand the benefits patients receive with passage of such legislation, and to me it makes no sense that Mississippians can travel 20 miles to my office in Louisiana to have these procedures done, and in some cases have, or that other doctors of optometry who are dual licensed in Mississippi and Louisiana and elsewhere can do them in one city but not in a neighboring city just across state lines. Many of our profession's best and brightest practice right here in the great state of Mississippi, and Mississippians need and deserve access to the full skill set these doctors of optometry possess. So it's my sincere hope that you will see fit to support this legislation. Thank you.
Okay, thank you very much. And now I think Dr. Crowder and Dr. Horn have a presentation. If y'all would come up and proceed however you'd like to. Dr. Roten, are you related to Joe? Are you related to Joe, who is in the house? Joe Roten was a member of the House, and he and Carl Wiesenberg were denounced by name in the Clarion Ledger in the 60s for voting no on the various legislation proposed by Ross Barnett. So years later, Joe wound up being a clerk for the bankruptcy court and was in Greenville, but moved to Aberdeen with the bankruptcy court, where he became my constituent. So when the lottery came along, I opposed the lottery, and I was one of 27 state senators who were denounced by the Clarion Ledger, and the Clarion Ledger called for our defeat. And so one day Joe calls me into his office and pulls out his editorial from the Clarion Ledger denouncing him. So Joe and I had that in common. Joe was also opposed to the lottery, by the way. I'm sorry, I see the name Roten and I go off on a tangent. Go ahead.
We ready?
Yes, ma'am.
Thank you, Mr. Chairman. Mr. Chairman and members of the committee, good morning. Thank you for your time and desire to be educated about patient safety and upholding the standard for every Mississippian to receive the very best quality eye care. My name is Dr. Kimberly Crowder. I am a board-certified ophthalmologist caring for patients from all over the state of Mississippi and from all socioeconomic backgrounds, along with my colleagues at the University of Mississippi Medical Center. I am not speaking for UMMC, but I have held a faculty teaching and patient care appointment at UMMC for over 17 years. During that time, I have had the privilege to participate in the education of countless medical students and over 50 ophthalmology residents. I have served in multiple roles for UMMC and the Department of Ophthalmology. Most importantly to me, as ophthalmology medical student educator, associate residency program director, and ophthalmology residency program director. For the past 5.5 years, I have served as chair of the Department of Ophthalmology. This puts me in the position of being the expert in this state in the teaching and training of students and residents to become quality ophthalmic surgeons. In my role as chair, one of the best decisions I have made was to hire an optometrist. She was the first one to join the faculty at UMMC. She and I both share the belief that it is in the best interest of our patients and colleagues to have collaboration between ophthalmologists and optometrists, and that this mutual respect and understanding starts at the level of training in both schools. However, As much as some experts would like to dismiss the difference in education, I am here to tell you that the path to becoming a surgeon in any specialty is a long and arduous one. It is absolutely necessary, however, to provide the best quality care and safety for our patients. There is no shortcut to becoming a competently trained ophthalmic surgeon, period. In order to understand the proper use and effects of scalpels, needles, knives, chemicals, and lasers on humans, one must follow the nationally required standard of training by going to 4 years of medical school, followed by an internship, followed by 3 years of residency training, and finally, 1 to 2 years of fellowship, as some of my colleagues at UMMC have done. I have listened to the testimony from other experts in optometry from other states when this same question of optometry versus medical education has come up. Time and time again, the 4 unbelievably rigorous years of medical school training, which optometrists do not receive, get dismissed by these individuals as being pointless. There is no attention paid to the fact that to be a surgeon, you need to start with months of direct training by surgeons in medical school. This includes days of assisting actual surgeries, years of direct but supervised patient care, and hours upon hours upon hours of practice in wet labs, simulators, and with direct observation by a surgeon, just to earn the privilege of sewing on what my colleague, the UMMC Surgery Department's medical educator, refers to as non-functional parts of a human, such as a torso or a leg. Certainly not an eyelid, where the repercussions of immaturity in surgical skill result in a lifetime of morbidity for a patient. Another quickly dismissed fact is that the reason that the UMMC residency program, like others around the country, will only graduate a handful of ophthalmology residents, specifically 4 each year for our program, instead of anywhere from 30 to 130 plus optometrists that are graduated in each class from every optometry school. The reason is not because I don't want to train more ophthalmologists. The reason is because if I have too many, I cannot provide the necessary quality and quantity of training needed to make them competent. Every single ophthalmology resident spends months and months of individualized, directly supervised apprenticeships with multiple subspecialized ophthalmology faculty surgeons, one-on-one, before being deemed competent to perform any procedure. An optometry student shadowing an optometrist does not make a surgeon. Each ophthalmology resident spends 12 weeks, one-on-one, in the clinic and in the operating room with our ocular plastic surgeon, with direct supervision while the resident removes lumps and bumps, sews eyelids from traumatic or surgical injury, and injects chemicals into eyelid tissue. 12 weeks, one-on-one, not a few hours with a teacher showing a PowerPoint slide or to a class of 30 to 100 plus students, and certainly not a dozen or so hours in a so-called training course on a weekend. There are only 4 ophthalmology residents per class because our residents need to spend months in comprehensive clinics and in retina clinics, one-on-one with ophthalmic surgeons in order to understand the indications for and risks of periocular injections of steroids or other chemicals, and the indications for and risks of using a laser. Things that are never referred to as simple procedures to our patients at UMC. During this time, the ophthalmology residents are examining patients and then individually directly observing multiple laser procedures and injections on humans, practicing with the lens placement or needle placement, and learning the dynamics of the laser before ever sitting in the driver's seat of the laser to fire that first tissue-destructing shot. Make no mistake that even though optometry experts testified that it is the laser that applies the treatment, as if some machine could magically have the cognitive ability to know what to do, it is not the laser, but the surgeon that uses the laser to destroy selective tissue for a purpose. It is no different than telling a novice marksman, if you can just look through the scope of a rifle, then you automatically know how to fire a gun because it is the gun that does the killing. It's not the gun. It's the person firing the gun that is 100% responsible for the results of that object. And untrained, those results can be disastrous instead of productive. This cognitive judgment and delivery cannot be learned in a few hours of a training course or among dozens of other trainees when it comes to the ability to treat a patient with a laser. I'm going to take a little break from describing what it takes to teach a student to be a surgeon and tell you about another teaching role that I've had to play this past year. I have a 16-year-old, and I am sure, as many of you have done, I had to teach her how to drive. First, let me brag on my 16-year-old's cognitive abilities. She is a straight-A student with numerous awards. That's not good enough to get you a driver's license in this state. She studied and took her written driver's test, and the officer who reviewed the results said, and I quote, "Dang girl, you didn't miss one of them. You got all the questions correct." Now, several of her friends had failed this test, so I was a very proud mom that she had aced it. But the proof of her cognitive ability to drive and know all the rules that were written in text still did not get her a regular driver's license, only a permit. So with this permit, she actually has to drive with a parent or guardian. The fact that she's watched my husband and I drive for 15 years, sitting in the car seat right next to one of us, did not count for training for driving. The fact that she can ride a bike expertly, drive a golf cart or other non-automobile motorized vehicle also did not count one bit for training to drive a car. My husband and I could not put her in a simulator and let that count as driver's training to get her license. She also couldn't sit in a car with 30 of her friends, or even one or two of them, and learn to drive. I actually had to put her in the driver's seat of my car and one-on-one go through the stages of learning to drive. Since this occurred during a worldwide pandemic, the school's driver's ed class was canceled. So we paid a driver's ed teacher to come work with her one-on-one for about 6 to 8 hours. This guy is the expert at teaching students how to drive. He said she did fantastic, wrote a letter for our insurance company. Was this time and opinion of the expert adequate for obtaining a driver's license under the laws of Mississippi? No. Why not? Because you find people who make the laws in the interest of public safety and the protection of all citizens know that there is only one way to produce a quality, competent driver. The only way to obtain the driver's license for me to ride in the car with my daughter driving, one-on-one, for hours upon hours upon hours. In the rain, in the sun, in the night and day, on interstates and back roads, in order for her to gain competence to be a safe driver. Since there is no officer driver's test during COVID, then I had to attest that I personally spent 52 hours minimum driving with my daughter, and then sign an affidavit, a legal document stating that I have done this training with her. 52 hours to drive a car, not a commercial vehicle, just a regular family sedan. Anything less than this set minimum time and this one-on-one training would put the citizens of Mississippi at risk. Driving a car is not laser surgery. You don't have to make straight A's. You don't ever have to earn a degree to obtain this skill. But to obtain it safely and competently, you need one-on-one instruction for 52 hours minimum according to the state of Mississippi. Why? To protect the public. This is no different than learning to be an ophthalmic surgeon. There are no shortcuts, dismissals, or so-called minor procedures. Stating that there are no complications in states where optometrists are allowed laser and other surgical privileges is incorrect. Stating that there are no reported complications is true because there is no mechanism or requirement to report mistakes made during these in-office procedures. It is like saying that the only drivers who break the law by speeding or running a red light are the ones who get a ticket. Drivers are not required to self-report when they break the speed limit. Similarly, it is incorrect to say that running a red light is only dangerous and detrimental if you get caught. So what does it mean if you diminish the importance of education and training required to become a competent ophthalmic surgeon? It means that you as lawmakers are telling the citizens of Mississippi that you do not support the expected quality of care for them in this state. That you do not require that practitioners meet the proven national standard of training and experience. That you want to drastically lower the standard. Additionally, some of our neighboring states have delivered this false message to their citizens, leading to consumer confusion. This only increases the risk to the average citizen who is unaware of the differences in training and education to make an informed decision about whether to have an optometrist or an ophthalmologist perform his or her surgery. It is well known that the vast majority of the public does not desire this type of legislation. It is also well known that only a minority of the population is able to discern the difference between the two healthcare providers before you today. We can make better decisions for our citizens in Mississippi. As a physician, surgeon, and educator, I have spent most of my adult life training and working to earn the trust of the public. I train young women and men who dedicate themselves to do the same. And now it is up to you as lawmakers to protect your constituents, assuring their continued trust. I ask that you stand up for the safety of our citizens. They are family, friends, loved ones, and they trust you to protect them, and we owe them this. I will say that is the prepared part of my speech. I wasn't going to talk about some of the other issues that were brought up, but since they were put in my lap, then I am going to say a few other comments in response to the earlier presentations this morning. As far as access, do have some handouts we can pass out that show that the patients on Dr. Reed's slide are all located within 30 minutes of a surgically trained ophthalmologist. 77% of Mississippi population is within 30 minutes of an ophthalmologist. 99.4% is within 1 hour. So the cities that he popped up, I can tell you the name of the ophthalmologists who are within 30 minutes because a lot of them I trained or I trained with them. I would ask you, how far do people drive to go to their favorite college sports event? Is all of their alma maters within, 20 minutes of their house? How far do they drive to go to their hunting camp? How far do people of Mississippi drive to go to a casino? There certainly aren't casinos all over the state, but I know our population will drive to go to those places. A comment on the malpractice insurance. So malpractice insurance rates are not set by medical boards. They are set by actuaries and insurance companies. And I understand I'm preaching to the choir because probably some of you can teach me more about this. But I do understand that it is a numbers game. And I'm friends with an actuary who said, that this makes sense that the rates would not have increased at this point because 45 of our states do not allow expanded surgical privileges. And in the 5 states that are remaining, only a very, very small number of optometrists in these states are actually performing these procedures. So it's a numbers game. The numbers aren't big enough since these rates are set nationally. The numbers aren't big enough with the majority of states and then the majority of optometrists even in the states performing lasers not doing surgeries. So the numbers game hasn't worked out yet for the malpractice rates to go up. The comment about the brain drain. I do know that the optometry board continues to issue more and more license each year. So I can't comment on where these people are actually practicing, but there are optometry licenses that are being issued at a greater number each year. The economic impact, I'm not sure because I spend my time teaching how to take care of patients, but I do know that our ophthalmologists, bring economic opportunities to our areas as well. Based on a peer-reviewed article regarding the increased cost of care by not allowing optometrists to perform surgical procedures, in the Journal of the American Medical Association in 2017, a study was done looking in Oklahoma, which, as Dr. Reed and Dr. Wooten had commented, has been doing laser procedures for about 30 years. So in that study, they took 1,400 eyes. They took 700 from ophthalmologists and 700 laser surgeries performed by optometrists. The patients who had laser surgery performed by optometrists were nearly 2 times more likely to have a repeat procedure in that same eye. So the cost is a little, that skews the message about cost just a little bit, because if you have to pay for the same procedure twice, then we're not saving the money of, that they're claiming with the office having to go to an ophthalmologist's office. Finally, let me start with saying that, and we'll pass out also a binder that has the full report, but Vermont did an extensive study, and I know they're way up in Northeast and almost a different country, but they did a really extensive study of this in 2019, and one thing, there were multiple issues that they had a committee review that was not affiliated, with either side. And, one conclusion was that they came to the conclusion that training is not the same, okay, between the two specialties. And then they also came to the conclusion that there was no significant cost savings. Finally, another thing that this report brought forth was evidence that looking again in Oklahoma, although only 3 cases of malpractice were reported by the executive director in that state, over 59 cases were reported by the national reporting mechanism. So the reports are very different, which is disturbing. As far as the Louisiana statement that there are 0 complaints, I mean, this hurts my heart because we do know that there are patient complaints. There is a patient, and I'm sure Dr. Wooten probably knows who she is, that has video testimony, that we're happy to share, and that is a patient who's willing to come testify. No, she didn't sue. You're right. So it didn't come forth as a malpractice case. But like I alluded to in my report, that doesn't mean that there are no complaints and no risks and no detriment. I really appreciate your time. This is my first time. No, it's actually not. This is my second time having the opportunity to do this. I came and spoke when I was a resident about 20 years ago. But I am here and happy to answer any questions. This is about my patients across the state of Mississippi. Every single one of them who needs me, I will be there, as well as my colleagues will be there for them. And I have 4 residents here if you have any questions directed toward them about the specific training that goes into becoming an ophthalmic surgeon. So thank you very much for your time.
Dr. Horn?
Thank you for having us here. We appreciate the opportunity to speak to you. When I was in medical school, we had a wonderful professor by the name of Dr. Peter Blake, and he told us to do the right thing. When we have all these questions about what to do, given a bad situation, and we're trying to figure out as young physicians or as medical students what to do, he'd always encourage us, do the right thing. And I urge you to do the right thing by looking carefully, listen to both sides, but then look carefully and discern
where the truth lies in these matters. Another maxim of medicine is to first do no harm. And you've heard a lot from Dr. Crawford about the potential harm here. I'd like to say that I also agree with our optometry colleagues. This is about the patients. I concur. We want to do the right thing for the patients. We have vigorous disagreements about how to accomplish that. Next, let's see. Mississippians, you've already heard, both sides agree that we deserve the very best high-quality care. You've already heard people outline the differences, and I'll leave that as I proceed to bring to you some comments from Dr. Cynthia Bradford, an ophthalmologist who is a professor of ophthalmology at the University of Oklahoma. And she was gracious to share some of her experiences and her thoughts about these matters. She said, first, as an eye surgical professional, it's so important to make the correct diagnosis. And she gave us some vignettes, some actual cases. And I'll just read this. After laser treatment for glaucoma was given by a state legislature, an optometry board-certified laser treatment optometrist saw a patient multiple times and could not make a diagnosis. The patient kept having pain. Interesting that in a social situation, the optometrist encountered an ophthalmologist and described the patient and asked what the surgeon thought. The ophthalmologist gave the answer, the correct answer. The optometrist did not act on it. The patient had more pain, ended up in an emergency room. The physician there made the correct diagnosis, referred the patient emergently to an ophthalmologist, and the patient pursued a lawsuit. So you first have to make the correct diagnosis. How do you make the correct diagnosis? By having the training and the experience to make those diagnoses. That takes years, as you've just heard Dr. Crawford tell us. Number two, knowing the treatment options and what is best and which one is best for the patient. You've heard the old saying, if the only tool you have is a hammer, the whole world looks like a nail. If you don't have the full range of tools necessary, you often don't do the right thing. A patient here was determined by an optometrist to need glaucoma laser surgery. They decided on treatment. Risks were not recognized. They proceeded with the surgery that resulted in bleeding the eye and elevated pressures. In the same session, they decided to proceed with surgery on the opposite eye, the second eye, and got the same result with bleeding and elevated pressure. They didn't know how to manage the complications and didn't see the risk because they didn't have the training or expertise to do so. Number three, know how to do all potential treatments. Patient was misdiagnosed and a procedure performed. It was not appropriate, but it was the one that the optometrist had seen and knew. They didn't know the right one because they didn't have the training or the experience. Recognize the complications, number four. And we've already discussed that. And know how to treat the complications. We've already talked about that. These are just a few examples from Oklahoma, which is held out as an example by a professor of ophthalmology at the University of Oklahoma. Experience matters. Dr. Crawford has done a much better job than I possibly could of outlining this, and this is just a bit of the highlights. The hours of training needed, I think, is shocking. By the time one of her residents starts going on their own in practice, seeing patients and performing the procedures that our optometry colleagues would like to have, they will have over 17,000 hours of direct supervised training. The average optometrist, maybe 2,000 hours, and much of it not nearly of the rigor or specificity that you will see in ophthalmology training. They're asking you to allow them to perform eye surgeries with scalpels, lasers, not now, we heard today. You also, when they said not lasers, you didn't hear them say not lasers in the future, just not now. Optometric education, from looking through catalogs and talking to people that know this better than I, focuses on a lot of the basics, basic eye care, basic eye exams, contact lens fitting, refraction, glaucoma diagnosis, referring people, doing all the basics. We need them. We like our optometric colleagues, as you've heard Dr. Crawford say. But they're not surgeons. They're not trained to be surgeons. There are a couple of myths that have been mentioned here today. We're going to just do minor surgeries. There are no minor surgeries. Anytime you violate tissues, living tissues, whether it's with a scalpel, a chemical, a laser, there's nothing, any of those things where you break the skin, you cut a tissue, you destroy a tissue, that is surgery. It's never minor. It all has the potential to go very, very wrong. And without the right judgment and experience, bad things are known to happen. The eye is not terribly forgiving if you make bad mistakes. Loss of vision is a terrible price to pay for having someone who was undertrained. You also heard testimony from our optometry colleagues that their medical school training covered the same broad range. The 4 years of optometry school were very much like the 4 years of medical school. Now, I've not been to optometry school, but I read through the course catalog. It was nothing like what I did. Nothing. Not even remotely the same. Our training, all 4 years of our medical school training, first 2 years are mostly books, the last 2 years are mostly clinical. All of it closely supervised. All of it prior to learning how to do a specialty. We have many, many more years of training, tens of thousands more hours of training. There's no comparison. The expanded scope of practice will not improve access to health care in Mississippi. You also heard Dr. Crawford just address this. There is no shortage of access to quality surgical care for the eye in the state of Mississippi. People are as close to their closest Walmart as they are to their closest ophthalmologist. Now, I know from my Walmart in Laurel, people come from, they will travel to get their groceries. They will travel to get what they want. There is no problem with getting quality eye care close to home. It's just as close as you'll go to do anything else. Also, the idea that is inferred that optometrists are going to locate in every small rural community in the state and perform surgical procedures there, well, it can't be true. A, it hasn't been that way in other states, and B, it won't be that way here. Why can I say that? It's not economically viable. It takes a certain volume of care you have to do a certain volume of these procedures to pay for the equipment to do the procedures. And you cannot, in these small rural communities that are 45 minutes or so away, there's not enough volume of care to be provided there to make them economically viable. It's the same reason that an ophthalmologist will not locate there. So people will be traveling to get their care, whether you pass this bill or not. We agree that optometrists are a valuable part of the team. They perform a valuable basic services, and they are wonderful at helping to take care of our population and their eye care needs. Ophthalmologists work with them daily. It is a close relationship. And I wish we didn't have to be here having this conversation. We do not dislike optometry. However, there's no substitutional shortcut, as you have heard, to learning how to properly perform quality surgical procedures related to the eye or any other part of the body. Patient safety matters, and no patient should be placed at risk because they receive care from someone who was undertrained. If you don't know what you're looking for, you can't see it. I saw this the other day and I thought, man, if you got to have Braille on the pilot's lounge sign, if you need to be able to read Braille to find the pilot's lounge, that's terrible. I want my pilot to have such clarity of vision that he or she doesn't need to read Braille to find the lounge. And I'm likewise committed to the position that those who would hold themselves as qualified to operate on our eyes have the required training and experience to know what they know what they don't know, and to have the integrity, honesty, and humility to know the difference. Talk to experienced physicians, and we will tell you every day how humbled we are by what we do and by how I live every day. I fear that I'm not getting something right, and that's with a lot more training than our optometry colleagues have. So it's so important that you have people that have the ability, the training, the ability, and the humility to be able to understand the differences. Surgical experience in an optometrist is woefully inadequate. Sometimes a couple of weekend classes at a hotel ballroom to be instructed on this laser or that laser, whereas you heard Dr. Crawford talk about the weeks and months and years of one-on-one training that they take. One last example, an analogy, it would be somewhat equivalent to allowing a novice Cessna pilot to take the helm of a 747 full of passengers in potentially bad weather. Why would you do that? Why would we allow that for the people of Mississippi? MSMA and its members strongly oppose this ill-advised request for expansion of optometry scope of practice. Thank you.
Thank you very much, Dr. Horn. I think that the members may have questions that would be directed at just generally all of you. I was wondering if you, Dr. Horn, and Dr. Crowder would mind just sitting here so that you could go to the microphone and answer questions as they come up from time to time. I just have a couple of quick questions. There was legislation that essentially, within certain restrictions, would allow the Board of Optometry to set the scope of practice for optometrists in Mississippi. Does anyone know how many states do that? Dr. Reed, Dr. Roten, Dr. Crowder, Dr. Horn? I'm sorry, could you please come to the microphone, such as it is?
It was a little difficult to hear what you were asking, so I apologize.
I'm sorry. I was asking how many states allow the Board of Optometry to set the scope of practice within certain parameters, sort of along the lines of the proposed legislation.
I don't have that number off the top of my head, but we can certainly get that information to you.
Okay. I think that would be useful. Well, since you're there, there is a map that has been provided by I think Dr. Crowder, which shows the states which allow laser, scalpel, and eyelid injections, and injections without lasers. And have you seen this map?
I don't have access to that right now. I've seen maps before, but
I'll ask someone to hand you a copy of it, and just take a moment and see if generally you agree with the states that are indicated there that allow these various things. Can you describe the procedures that optometrists would want to offer, assuming, of course, they had requisite training in these areas, if the Board of Optometry were to authorize additional procedures, or if we were to do it by statute, or however we would get there? What are the things that you would want to do that are not currently permitted?
if I may, I would like to ask him to come up here with me since
Sure.
he does those. So, yeah. Yeah, okay, so in Mississippi, we mentioned the word laser, of course, it's a big scary word, but there are several laser procedures that we are trained to do, we'd like to do. One involves, and I don't want to give you the technical names of it, but I can describe it to you. One involves when you have cataract surgery, there's a film that sometimes grows in about 51% of patients on the back of that implant. and there's a laser procedure that can clean that in just a matter of a few seconds and get that patient seeing clearly again. Another that was brought up today, there is a laser procedure that's used sometimes, not often on frontline, but sometimes in glaucoma treatment, in which you are able to control the patient's pressure without the need for medication, or at least lessen the medication, which sometimes the more medicine you have, the more compliance issues you have. And that's something that Dr. Roten currently performs. When we discuss, there are occasionally some small lumps and bumps, we call them, on the eyelid margin that need to be removed. We're not talking about gross cancerous areas or things like that. We're talking about small bumps that need to be removed for the health of the patient and overall just cosmetic appearance in some cases. Those are some of the ones. Of course, anytime. Let me ask you first, Dr. Roten. Do you have any other ones that you normally?
Those are the most frequent.
Yeah, those are the most frequent ones right there.
So generally speaking, and I'm sorry, I'm sure I'm describing this incorrectly and all, but just sort of dumb down layman's view of this, or dumb down legislators' view of it. I mean, we'll look at, there are, as you say, lumps and bumps on eyelids that you would want to remove.
Right. For example, most people have had a sty, I would think. And a sty, sometimes if it doesn't resolve completely, it leaves a bump. There's a non-infectious bump. We call that a chalazion. And that is unsightly and can create some vision issues if it's large enough to push on the eye. That's easy to incise and remove for the patient and not have to go further with that. That's an example of a bump.
Is that something you would do with a laser?
No, sir, that one would not be a laser. Sometimes you can do an injection into that and make it go away, and sometimes it does involve making a small incision. But as I was saying before, that is not an incision in the eyeball itself.
It's the eyelid.
Eyelid, that's correct. Yes, sir.
And then the laser procedures involve removing this film that comes from after cataract's removed, and occasionally for treatment of glaucoma.
Right, that's correct.
Okay.
That's correct.
Thank you. I know members of the committee have other questions, and you can address them to individuals or specific people or however you'd like to go. Senator Wiggins.
Thank you, Mr. Chairman. I have a few questions, and one, there may be a couple for everybody to comment on, or a couple from both sides, and then a specific question. So one that I'm asking for just a comment from both sides. I was looking at the end of the day, we're passing laws here, and under the current law that was done before I was ever here and others, just looking at it in the definition of what is optometry, there's a laid out definition, and it specifically prevents laser surgery. In what the state of Mississippi through us define as physicians, it says, the law says, every person who desires to practice medicine must first obtain a license to do so from the State Board of Medical Licensure. So we, the legislature, have said we're not defining what medicine is. We're allowing the medical licensure. And then we put into statute what the optometrist says. Can you comment on why that is? And I know you're not legislators, but why that's the case? Dr. Trotter?
So I would assume that the people who came before you who set these laws recognize the importance of medical, surgical procedures being performed by a medical doctor. And so that is not, being a legislature, that is my assumption of why that statement is in there. Is that what you were asking?
Yeah, I think so. That we've said we rely on the Board of Medical Licensure, who dictates what is the practice of medicine for physicians.
And I agree, they do dictate what I can do, along with, that there's also layers, and I don't think that that's really clear. It's not just the Medical Licensure Board who watches everything that I do. It is also my hospital, and so, if I have to take a patient back to surgery unexpectedly, within a certain period after surgery, that gets questioned. It's not that, the hospital itself doesn't wait until there's so many cases or so many complaints that the medical board hears about it. And then further down within my own department, we do morbidity and mortality reviews within our own department, and other ophthalmologists practicing, within other health systems. Things aren't waited until it's reported to the medical board. There are other mechanisms in place watching outcomes. The other thing that ophthalmology has that's really key for our outcomes as a whole, and making sure we are setting standards of care, is we have a national registry. It's called the IRIS registry. It links to all of our EMRs, okay? And so our data automatically gets reported, okay, to this national registry that then gets reviewed by the American Academy of Ophthalmology as a whole to make sure that we are maintaining standards.
Okay, Dr. Reed?
Optometry has been evolving as a profession for many, many years, and certainly I'm sure the very first time we had to come before the legislature, that was the mechanism that was in place for us to be able to train at the level that to practice the level we were trained back many, many years ago. As you guys have been around for quite some time, we often have to come back to you because as training and as various procedures come out, we constantly have to come back to you to ask you, can we do these procedures? It would be and should be a very easy thing to do to let our state board decide that for us and not have.
Well, I think that's what Chairman Bryan was mentioning, if I'm not to put words in his mouth, but
Yeah.
I think that's what he was asking.
Right, and I told him we could get back with the information on other states there. It's it is interesting though that not everybody who's regulated by their board goes to med school. Dentists don't go to med school. So.
Right, and just on that, there's a definition that the legislature is put in the law as to what is the practice of dentistry versus the medical board. So, okay. Right. So my next question is, I wanted to go to the Journal of American Medical Association and the report, or the report that was talked about. Dr. Trotter, you used the word peer review. Can you just tell us what peer review means? Or Dr. Whoever wants to describe that, what that means.
It takes years to get things into textbooks, and so continuous learning for all of us happens on a weekly and monthly basis through the magazines, we call them journals, which publish quality studies, which in order to be counted as a quality study, it needs to be peer reviewed. And what that means is that a bunch of different ophthalmologists review the literature so that what is published is unbiased, and not just ophthalmologists, but statisticians and other medical experts review literature before it is put in our journals or our magazines to update, us continuously on current practices and current knowledge. And so the Journal of American Medical Association, that's not just an ophthalmology journal. That's a very well-respected medical journal read, by the majority of physicians in this country. So not only does it matter that your studies are peer-reviewed, but to have something that is accepted respected, and that level of a journal just speaks for the quality of the study.
And so it's based on scientific principles.
Correct.
And peer review is the procedure for ensuring that
Validating.
it's validating and it's not random and it's all of that kind of stuff.
Correct.
Okay, so that's what you meant by that. And in the study out of Oklahoma, their finding was that case logs show the ophthalmological residence performs 14 LTPs and 83 procedures during residency. In Oklahoma, training of optometrists to perform lasers involved a 2-day course. Is that what you were getting at?
So for me to train a resident, I have national standards set by the ACGME, or the American College of Graduate Medical Education. And so I have national benchmarks which I have to check to be an accredited residency training program, okay? For my individual residents, though, it is ultimately up to me to sign off on them individually, and my program and director and I will actually have to sign off on every single procedure that we have trained these residents to do and state that they are competent to practice them independently.
Okay, and in that, the results of that study stated their conclusion was health policymakers should be cautious about approving laser privileges for optometrists practicing in other states until the reasons for these differences are better understood. Right. Does anybody know whether, and this was in 2016 or 17, and I'm asking Dr. Reed and anybody whether reasons for these differences have been published or better understood since that time?
Can I just comment that you have to look at the numbers, okay? I have 122 residency programs across the country that graduate about 600 residents each year. There are only 23 optometry schools, and the data that I found was that there are 73 or 7,400 students in these 23. So consider the numbers to train. Okay, 122 residency programs are graduating 600 a year. 23 are graduating, I guess if you do the math, that's about 1,800. So, the numbers speak for themselves.
So in other words, we don't have any other data of why these discrepancies are better understood.
I don't, but.
Huh?
I don't.
Okay, does anybody else have any information on that, Dr. Reed?
Certainly, as optometry has performed more of these procedures over the years, the training courses do give as much exposure as possible. One thing I want to highlight in comment to Dr. Crowder and her comments about the training. So if you're trained to be an ophthalmic surgeon, as ophthalmologists are, then you're going to spend probably the vast majority of your time focused on the complex cases. Now, you mentioned that word simple earlier, and the reason we simply say simple, it's not that it's a simple thing as in we just flippantly think about it. It's that there's a difference between pulling an eyelash and expressing a bump from doing cataract surgery. So when you look at all of these hours, they're going to be mainly focused on the 80% of those complex cases. That's primarily what they are focused on doing that. So, yes, if you look at the numbers, there are more optometrists graduating than residents, but that doesn't mean that we are having less exposure because we're not focused on those major complex cases during our time. They have a 3-year residency, and during that 3-year residency is when they focus on that. So if you want to do the math and look at the hours that we're actually trained, there are 1,000 to our 2,000 or 17,002. Yeah, we're going to train the appropriate number of hours that it takes to get that done. I also want to point out it's ophthalmology that trains us, okay? It's not like we're all training ourselves. So if ophthalmology is training us, then for us to not have the judgment and the ability to do that, that means that they would be training us incorrectly, and I don't think that would be ethically so.
Okay, and so can you, I mean, what's your take on the Journal of American Medical Association and the Oklahoma findings that essentially had to come back where there was a higher incident of having to do it again when there was an optometrist that had performed the procedure? What's your response to that, or what's the reason behind it?
Yeah. Okay, yeah, let me tell you. So, as I mentioned, we're trained by ophthalmology to do these procedures, okay? You can do this laser procedure on half the eye at once, or you can do it all the way around. And at the time, the standard was to do half and then come back and do half later. A lot of ophthalmologists weren't doing that. They were doing the entire eye at one time. So it looks like we're doing twice as many procedures in that study than what we really were, because we're following the standard of care at that time as we were taught.
Okay, and Dr. Horn, I have a question. Where's Dr. Horn? So the access to care, and I've heard that. My question is, I guess anecdotally, it's been my experience, even in my area, which I would consider not necessarily a rural area, that we have a problem getting into ophthalmologists. I will give a for instance, that we had a ophthalmologist's office closed recently, and it takes 2 months to get a doctor's appointment in an ophthalmology office. So the access to care issue is a real issue. I've had these discussions, and so with I think State Medical and others, what is being done outside of what the legislature has worked on in different capacities to get ophthalmologists in areas that are having a lack of access? My guess is if I'm in Jackson County and it takes me 2 months to get an appointment in an ophthalmologist because my ophthalmologist left, I can only imagine what's going on in the Delta. So what's being done on that?
Well, the Mississippi State Medical Association has been working with the legislature and with University of Mississippi Medical Center for many, many years. I came through when our class size was 110, and now we're at 165. And part of the problem has been adequate training for physicians. Now, there's only so many, as you've heard from our ophthalmology professor, there's only so many ophthalmologists that you can train at a time. The problem is the surgical access. Yes, routine eye care you can get, and our optometry colleagues can do that. It's the surgical procedures we're talking about. So I don't know about the circumstance you're talking about, if it was you could not get to someone for eye surgery in a reasonable time frame, or if it was that you needed some routine eye care, an eye exam, some eye drops, I don't know how to answer it other than to say our numbers and our data tell us there's not a lack of access to surgical eye care. If you know something different, please let us know and we'll work with you.
Well, I just gave you my instance, but
Well, I didn't know, was that a surgical case?
well, no, in this case, the ophthalmologist's office closed, and people all around the county were trying to get into other ophthalmologists, and it was taking them 2 months. And nobody else has come that I know of. So I think that's part of the issue that we're dealing with here. And our constituents talk about, at a certain point it kind of bubbles up and said, I can't get in for 2 months. I need to go see somebody.
Well, and again, it comes down to what we're discussing here today, I believe, is expansion of optometry to allow surgical treatments. So that gets back to the question of, is that lack of access to surgical eye care, or is the lack of access to routine eye care? And those are two different things. Already we have optometry to assist us with the routine eye care. What they're asking is to do surgical treatments that we believe belong only in the hands of those people who are best trained to do it.
Okay, and last question, is surgery, and I'm using, I guess, in the broadest term possible, is surgery considered an invasive procedure?
I'm not aware of any surgery that is not invasive. It's a violation of the normal skin, tissues, separating tissues, and doing some, so yes, surgery is, yes.
And would I be correct in saying that the trend in medicine, and particularly surgery, is to go less invasive,
There are
Prove it.
certainly the
Go ahead.
advances in imaging and in minimally invasive surgical techniques, but those are very advanced surgical techniques that take an exceptionally long time to master, like robotic surgery and a lot of these other things. They don't make things, they look simple on the surface, but in reality, they're very complex.
What is the biology? Why would we go for less invasive? And I'm talking biologically. Is it better? In other words, is it better for the patient versus cutting somebody open versus being able to do it some other way?
It's easier to heal. Why go for a complete gut and remodel when you can just do a little facelift on a home? It's less painful, less expensive, takes less time, get through quicker. So minimally invasive procedures, though they appear to be less complex, they're often more complex, but they do allow patients to recover more quickly and often with better results.
Okay. Thank you, Mr. Chairman.
Senator Polk.
Thank you, Mr. Chairman. My question will be for Dr. Crowder. Can you tell me, I'm going to follow up on access to care that Dr. Wiggins brought up. Do you know in the last 5 years what our plus or minus of ophthalmologist license to practice in Mississippi is?
To my knowledge, it's been fairly stable. Yes, they are retiring, and there is a group that is decreasing their amount of work, but thankfully, and partial thanks to you, we have this very vibrant residency program, and a lot of my graduates thankfully stay in our state.
Okay. And that very vibrant program, I think you said was 6 or 7 per year?
It's 4 graduates per year.
Per year, okay, less than I thought. Let me ask you a question. Have you had an opportunity to see what the Optometrist Association is proposing for there to be allowed to do?
So I know what was on the bill last year.
Okay. Using that information, talking about how long it takes sometimes to get in to see an ophthalmologist, is anything on that list from last year a surgery that you would drop what you're doing at that moment and and take that patient?
So the problem with the list is that they specify what they will not do. They leave open a potential for up to 200 procedures that they will do. So yes, some of those things are more urgent than others. And so, like I said, the issue, that I have with the bill is they state they won't do retina surgery and they won't do cataract surgery, but the door is wide open for a lot of other things. And with the access to care, I completely agree with Dr. Horn. I am not asking that we have fewer optometrists. I am not asking that our optometry colleagues don't continue to do the incredible job that they do at seeing the volumes of Mississippians that they see. No, we need this to be a collaborative effort. We are focused only on surgical privileges, and there has not been a Saturday or a holiday that has gone by that me or my team has been called by an my ophthalmologists have been called by an optometrist if they were seeing somebody that they felt was something urgent, that we do not say, yes, I will see them today, I will take care of the patient.
Okay. So, Doctor, if we reversed it and told the Optometrist Association, we'll look at your bill, but you list the 50 things you want, surgeries you want to do out of the 200 you talked about. If we took the 50 less invasive or less difficult and had that on the list, would any of those 50 be ones that you as an ophthalmologist would drop what you're doing to take?
It's all very individual specific, and every case is different in every, way that it presents. I can't make the statement just that broad that, you know, that there's never anything urgent on the lid, what if the chalazion is actually an abscess? What if it is tracking back behind the orbit and getting, and can, cause vision damage if this infection gets to the optic nerve? Every case is different.
Okay, thank you.
Senator Parker?
So I guess I'll just make just a general statement here first, and then I'll kind of move into questions here. Yeah, I kind of find myself in an interesting position on this because, as everybody in the room probably knows, I am an optometrist. Just my history in this issue, back in 1994, I sat in this room back in the group here with my white coat on as an optometry student. Came down in a bus because some people knew that we were going to be talking about scope of practice. And I came in this room and I knew absolutely nothing about what was going to take place. I came in here and I listened on that day to different people. I can tell you the names of the people who were here testifying. One of them has passed away now. Some of the people in the gallery, though, are the same people who are here today in the gallery. And how I left the meeting was that the people in the room had no understanding at all about what I was being taught, what I was doing in school, and what I was learning. And I sat in this room and I had everybody tell the committee that if my profession got the ability to do something like a corneal foreign body, or use an oral antibiotic, or use a topical glaucoma medicine, that people were going to die, and that eyeballs were going to fall out, and that the world was going to end. And I left this room just totally depressed. But what it taught me was how important this process is. And what the process involves is education of the members of this committee, educations of people who practice different professions, because I have not been in a medical school in quite some time. I work every day with ophthalmology residents in my practice, and I work with optometric residents in my practice. The optometrists who are training in my practice go and they do an ophthalmic surgery residency rotation with Dr. James Linder up in Memphis. They see lumps and bumps. They walk and they work with him every day, and they see that happen in the doctors that I train in the profession of optometry. They also go from my practice into the ASC that is connected to my building, and they watch cataract surgery take place down the hall from my office. They stand there right with the ophthalmologist and watch it, and they learn how that's done, not because they want to do that procedure, but because they are the people who are going to be handling those patients after the fact. Because in our practice, our mode of practice in a smaller town is that the patient sees the optometrist until they need the procedure. The patient is scheduled to meet with the ophthalmologist for surgery, for example, cataract surgery. And the day after the surgery, the patient comes back to me. Every patient who has received cataract surgery in my office for the last 25 years has had their day one post-op with me. And I will say, it is fair to say, as somebody who's been in practice, for quite a while, I've probably seen as many interesting cases as Dr. Crowder. I've seen Decimase detachments. I've seen dropped nuclei. I've seen ruptured capsules. I've seen vitreous loss. I've seen every single thing you can see. I've seen, a globe that's leaking, just everything that you can see. And that has helped me as a doctor to train the students that I train every day to a greater and greater level as we go along. Where I guess my angst comes on this is that I don't think we do a good job as optometry and ophthalmology in working together to teach each other what we know and do. I know this year we have a new cataract surgeon who's looking to be joining our team. He's a great young man. He does not have as many hours as a typical surgeon has because of COVID. He did not get as many hours, and there have been some obstacles, but we're working with him to try to find a way to draw him into the practice and get him the experience he needs. But I'm nervous. I'm nervous because I have a cataract surgeon ophthalmologist who, because of COVID, got a little less training than is typical. We also, in my practice, one day a week, we have a retinologist, Dr. Stephen Charles, one of the more renowned retinologists in the region, who sends his team down to my office. He sends his ophthalmology fellows down to my office. They sit in my office with me and we talk about cases before they do intraocular injections, and we learn a whole lot from each other. My students who work with me in my practice go up to his office in Memphis one day a week, every Tuesday, spend an entire day there seeing just strictly surgical retinal cases and learning from them, because what I want the students who contact my office to do is have the best ability to do the procedures that they're trained to do and understand the procedures that they don't do so that they can properly explain those to the patients as a whole. Some of the procedures that are being mentioned today, and as members of the committee, it is very difficult for me to explain all of the procedures that are done in eye care. Dr. Crowder and I could go for lunch after this. We would have a great, robust talk about interesting people we've seen, because I'm sure in a similar number of years we have seen some of the craziest things you can ever imagine. I've had people, come into my office. One gentleman come in, had a piece of metal had been stuck in his cornea for 4 days. He proceeded to tell me that on a Saturday his buddy had tried to remove it with a toothpick. He told me that on a Sunday his buddy decided to take his pocket knife and was going to try to remove it, but when he got close to his eye, he chickened out, and so he had to come see me on a Monday. And what I did in my office 15 years ago is I took my little instrument equivalent to a scalpel. I removed that piece of metal from his eye. I took another instrument that's similar to a little drill, and I drilled the rust from his eye. I put a bandage contact lens on him. I saw him every day for several days until he healed. That's what we do in optometry. That is not going to be told to you in this meeting. But I've also had patients. One of the procedures that we're asking to do is a peripheral iridotomy, which is a laser into the iris to help reduce pressure in an emergent situation. Unfortunately, in my practice, I have had the opportunity to see several angle closure glaucoma patients in my time. And those patients, when they have that condition, are in pain, they're in distress, and they are in trouble. And if their pressure is 50 or 60, we know as optometrists and ophthalmologists that they are losing vision minute by minute, not month by month. They are not able to get in their car and drive to the nearest Walmart equivalent of an ophthalmologist to have that laser done. And so we call the ophthalmologist and we try to find somebody, and unfortunately it seems to be the most inopportune time for everybody when that occurs. So I would love in my practice to be able to use an instrument that's sitting in my office to zap the peripheral part of the iris to lower the pressure, to then allow the glaucoma surgeon that I work very closely with to decide what additional procedure might be needed in that situation, if any. Because as we know, sometimes a PI is enough that we need to do, and we can debate our thoughts on that, but I think we both, Dr. Crowder, share the thought that there are situations like that that are important. Another laser procedure that we're asking to do is, as Dr. Reed has mentioned, it's a laser capsulotomy. It is basically when you have a cataract removed, the entire inside of the lens is removed, but you leave the rind or the shell of the crystalline lens in place to hold the implant. We have seen great advancements in implant surgery over the years. That's one of the things I'm most proud of in eye care, is that we've advanced so much, but we still, after that procedure, see patients who heal. And I tell younger people who have procedures done for that to expect to need a YAG capsulotomy. Some of the older patients, quite frankly, don't live long enough to need a YAG capsulotomy. But unfortunately, in our practice, our surgeons' volume has been so great that when we schedule YAG capsulotomies, there were times in the last year that they scheduled 20 YAG capsulotomies in an hour and a half. The patients came in, were dilated, they were just rolled through as quick as they could, because unfortunately, there is not enough time for all of the eye care that is needed, in my opinion, in the state. So we have to be working together to find some common ground and figure out what the procedures and what the things need to be so that we are working together. Primary care, in my opinion, has changed since I started in '95. The needle keeps moving. I talk all the time with our retina surgeons about the days of the photodynamic therapy and PDT and the other things that we thought were going to be great mainstay treatments for retinal conditions. And I talk now about how we're using Avastin and Eylea and Lucentis and these other agents every day in the office for conditions we did not know about. And then I also talk to the residents about how my wife with her cancer was also put on Avastin because we learned some things about certain conditions where tumors react the same way in an anti-angiogenic fashion that certain conditions in the eye do. But we are continuing to learn, and I continue to learn every day about these conditions. And so my frustration comes from, and I'm sharing a few moments of my life on this, because it's hard to a committee to explain all of the things that you know and all of the things that you know to do, and give you justice and understanding of that. But there has to be some common ground where we can do that. I was very disappointed last year when I learned that the Optometry Association had asked the ophthalmologist if there was any common ground that could be achieved on this matter, and I was told that there was absolutely none, that there was nothing that could be given. This is what I was told by numbers of members, and that's why we sit here today, is because there has been no willingness for any compromise. I was also told just shortly ago that ophthalmology has been working on a compromise bill without optometry being at the table. And I don't understand how that can be possible. To me, a compromise involves parties working together, and I would welcome the opportunity as both a senator and a legislator to sit down with people and say, what could and what should we be doing? Because I know what is taught in the schools, because I have the same resident interns who are training with me that Dr. Crowder does. They're in a different profession, but we have the same charge and the same job. And if we do not do our job, we don't turn out the right doctors into the community. And so I know I've gone on to a little narrative here, but my question to you, Dr. Crowder, and my question to you, Dr. Horn, is would you be willing to sit down with me and to talk about the procedures and some of the medicines and the things that we use and that I can tell you are necessary in our community, and to try to find something where we could get common ground on this, or not?
So respectfully, Dr. Parker, I believe surgery by surgeons. I believe that the standard of care is set
So
for a
your
reason.
answer is no. Is that no, that's all I want to know?
Surgical procedures,
So
it's
should
not
I
the
be able to
routine,
do a corneal
it's the
foreign body
complex.
removal in my office that I've been doing for 25 years, or should I be prohibited from that today because you consider that to be a surgery?
You are permitted to do that. I'm
But
not
is that a surgery?
asking that we change anything that
Is that a
already-
surgery?
I believe that,
Is a corneal foreign body removal a surgery?
so it is a procedure. It is not the same as lasering tissue inside the eyeball.
Would you be more comfortable with me doing a YAG capsulotomy on you as someone who has learned a slit lamp over 30 years, or more comfortable with me digging a piece of metal out of the front part of your cornea?
So
You as the patient.
this is about the training.
No, this
and
is
the
about this
years.
meeting. So this is about this meeting. I have spent 25 years wishing that I could sit at this table and ask questions with the knowledge that I have, and I just have a couple of small questions. And so would you be more comfortable with me doing a laser capsulotomy on you, or me doing a procedure that I've been doing for 25 years? Or is the answer neither?
I mean, I'm not sure why to you these things are the exact same thing.
Well, I asked if there was any common ground where we could talk, and then you told me that ophthalmologists do the surgery and optometrists do not. And so I'm asking you, of the surgeries that I do now, would you be comfortable with me doing that? And is that more or less dangerous than what we're proposing in the legislation as you remember from last year?
The legislation is not involve removal of corneal foreign body.
Is that a surgical procedure?
It is a procedure. I am
Is
not asking that you
what
not
number
do
of the
cornea
alphabet
foreign
of
body
what,
removal.
what number does it start with in the CPT code book? Does it start with a 9 or does it start with a 6?
I honestly don't know.
Okay. Surgical codes in general start with a different number than an in-office procedure code does. So, for example, cataract surgery, for example, is a 66984. Postoperative, modifier on the end of that is a 55 modifier. Most surgery codes start with a 6. And so corneal foreign body removal starts with a 6, which in the CPT manual defines that as being a surgical code. But you are uncomfortable with optometrists doing any surgical code at all, even ones that we have been doing for 25 years. Is that?
I expect you to continue to do corneal foreign body removal, and the CPT codes have nothing to do with defining training. They are set by a totally different governing body than
Right, and so if
training standards.
if they're not related, then how can we disconnect the two and say that everything that we're asking for is major surgery that you're not comfortable with, when there are already instances of what I guess I'm hearing now, minor surgery, that you are comfortable with me doing? So how can you and
I'm not
I...
asking to change anything that's already being done. I'm not sure why that's coming forward.
Well, I'm asking, again, if there is any willingness by you as a spokesman for ophthalmology to sit down with me or with other people like the chairman and have a conversation about what could or should be done together.
Yes, there is willing to sit down and have a conversation.
But that does not include any of the things that we're asking for.
It depends on exactly what's being asked for. The door was left wide open with the bill last year. Surgical procedures are not something that myself feels comfortable allowing patients to have surgery by anyone but a trained surgeon.
Except for the ones that we're doing now.
I'm not asking that we change anything that you're doing.
But you're still not answering so
Yes,
are you
I'm
uncomfortable?
not opposed to
Are
you
you
removing
uncomfortable
cornea
with
foreign
some of the
bodies.
things that we're doing now?
I am not.
Okay, so
I'm
if
not
those
asking
are,
anything to be changed.
if those are minor surgical procedures, should there not also be a list of other minor surgical procedures that in the last 25 years have changed as far as the paradigm of care that might be worth discussion?
I am not opposed to discussion.
Okay, and then just another question, because we've also just over the years we've fought on different issues as far as different classes of drugs and things like that. Would you be comfortable with optometrists using antiviral medications?
I'm not speaking about medications today. I'm speaking about surgical procedures.
Just a general
Mr. Chairman,
question.
in a court of law, I think we would object to irrelevancy on that. Is that where we're headed on this?
Well, I'm just trying to find if there's any common ground that we could find here. Would you be, okay with an optometrist using an antiviral?
I'm not prepared to make that statement. I came prepared to discuss surgery.
Okay.
And so, this is going a little bit beyond what, was relevant to last year's bill.
I would say that we're getting fairly close on time, and so we,
I do thank you for your time, and I do wish that we could talk more. And in answer to my antiviral question, we are using antivirals. My wife had shingles that popped up on her 2 weeks ago in the middle of the night on a Sunday, and we got up in the middle of the night. I called Walgreens, called in Valtrex, started her on the medicine right away. She also ended up with herpes zoster ophthalmicus. She had the classic dendrite. I treated that with the proper antiviral medicines. And I just find it interesting that when I ask a question to you as to whether or not optometrists should use antivirals, that your response is not just immediately, well, you're already doing that. It just shows me how far we are apart in our knowledge of what each other do, because I think I understand the problem, and the problem is not what we're asking for. The problem is the understanding of training by both sides and a willingness to find a common ground that's best for the people we represent. So thank you, Mr. Chairman.
Senator Witherspoon.
Yes, ma'am. Yes, ma'am.
Thank you. As far as who can perform surgery, the education part has been set. So I think that's about what I wanted to say. I just wanted to know that, wanted to talk without using medical terms, because I saw how you all was throwing out the medical terms, and to me, I don't know what that is. That doesn't mean anything. But we're here today. It's not about this meeting. It's about going forth with this decision. And I guess I just want to conclude by saying the standard of care has been set. The education, who can perform surgery, ophthalmologists and optometrists, has been set. Thank you.
Thank you very much.
You have time for one more question if there is one. If not, thank you all for coming. I have just a, I'm sorry, Senator Blackman,
Thank you so much.
it's Senator Kaufman's fault, It's blocking my view.
Can you tell me how much does it cost on an average for someone to go to optometry school?
No, I honestly can't.
Can you tell me on average how much it costs to go to medical school?
For tuition and board, there are financial opportunities for anybody who is willing, as well as this great legislative body for the state of Mississippi is willing to pay for medical students who are willing to go back to rural communities to pay everything for them. So yes, there is a cost, but it's not applicable to every person who arrives in the front door of the University of Mississippi Medical Center.
Would you say that it's substantially more, is it, to go to medical school than to optometry?
Yes, ma'am, I would assume so, but I don't know the tuition for optometry school.
And the surgeries that the optometrists are requesting, the laser, well, I think one said laser, not now, scalpel eyelid injections, do you know how many states allow optometrists to do this now?
The laser, scalpel injections, all three of those together are allowed in 5 states. There has been hundreds of presentations to legislation all over the country, though. It's not just because this question has only come up in 5 states. These are just the 5 states that the legislators have made the decision to proceed with expansion.
And so if Mississippi were to allow this, we would become the 6th state.
Yes, ma'am.
Thank you.
Thank you. I think it does better for me to take this off while I'm talking. But thanks to all of you for coming. the following things would be useful to me. The first question is how many states allow their boards of optometry to determine the scope of practice, or alternatively to determine the scope of practice with certain limitations. That would be helpful. Secondly, it would be helpful to know which specific procedures optometrists, just in general terms, are most interested in being allowed to perform. I understand the philosophical argument that the board should be able to determine the scope of practice or to do that within limitations. But apart from that, what are the primary procedures that optometrists feel like those who are trained should be allowed to do, and how many states do that? I have this map that the ophthalmologists have provided us with, which I assume is available to the public. I would be interested in knowing whether the optometrists agree that that's correct or not. And if y'all could just get that information up and get it to me, I'll share it with members of the committee. I would say also, insofar as various groups meeting and talking with each other, that's fine. And it's great to talk and have compromise proposals and all of that. But regardless of how unfortunate it may be, the ultimate decision about the law is going to be made by the 174 individuals who somehow managed to get themselves elected to this body. And maybe they didn't all realize this is what they were getting into when they ran, but they are. And so quite apart from what anyone does or does not agree to, ultimately it is the responsibility of this body to determine what we think is in the best interest of the people. This meeting today has been my attempt to get members of the committee some information so that they would have more knowledge and information as it comes time to make a decision. It's my intention that sometime in the 2021 session, preferably early in the year, we're going to be taking up some legislation and voting on it. And members need to be aware that that's coming and start scratching their heads and thinking through where they'd like for the committee to go. If there's nothing else, I would just make one final reference to one other foregone legislator, which seems to be a theme, also from Greenville, this being Hanen Miller. And Senator Wiggins read from a statute which begins, one who desires to practice whatever it was, some form of medicine must obtain a license. Senator Miller always said that's not true. You do not have to get a license in order to desire to practice medicine. You only have to get a license if you're actually going to do it. And with that, we'll stand adjourned.